Welcome to the TxRx Medications for Substance Use Disorder Echo. Please note that we are recording these sessions for later distribution. Please note that anything listed in the chat will not appear in the recording. My name is Shreya Prasanna and I will be facilitating today's session. A few quick announcements before we begin. To help us with attendance, please enter your name, affiliation, and email into the chat, which can be accessed by the speech bubble icon on the navigation bar from the bottom of your window. If you are one of our BWell Texas providers, please make sure that you identify yourselves during this session. If you are joining via phone, please email your name and phone number to bwelltx@visca.edu. Some housekeeping, please stay muted unless you're speaking. If you've joined by computer, your mute button is at the bottom left of your Zoom controls. If you're on the phone, just press *6. We encourage everyone to speak at these sessions, especially during the discussion portion. We want to hear from as many of you as possible, so please keep your comments brief to allow time for others to speak up. You can also use the chat feature to share your comments and questions. Please note that no protected health information is allowed in either the chat or the discussion, and that includes names, emails, addresses, dates, or any information that can easily identify an individual. If you would like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. Towards the end of the session, the BWell Texas team will send out a link to an evaluation survey. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. Our didactic today is on benzodiazepines and buprenorphine prescribing and will be presented by Dr. Sidarth Wakhlu. Following that, we will discuss a case presented by Nelly Zuniga. We will start with some introductions, followed by didactics, BWell program announcements, case presentation, and open discussion. Thank you all again for joining today's Echo. We look forward to learning alongside you and I encourage you all to share your experiences, questions, and insight in today's conversation. And with that, we will do some introductions. Dr. Wakhlu.
Good afternoon, Sidarth Wakhlu. I'm an addiction psychiatrist by training, professor of psychiatry at UT Southwestern. I'm the director for the Addiction Psychiatry Services here and also the director for the Addiction Psychiatry Fellowship. Thank you so much and welcome everyone.
Thank you so much for joining us. Dr. King.
Hello, everybody. I'm Van King. I'm an addiction psychiatrist here at UT San Antonio and the medical director of BWell Texas. Welcome, everyone.
Thank you so much. Dr. Walker.
Good afternoon, Crystal Walker. I'm a doctorally trained PA, and I'm the director of the Substance Use Department, Clinical Services and Medical Services for MHMR of Tarrant County in Fort Worth, Texas.
Thank you so much for joining us. Nelly Zuniga.
Hello, everyone. My name is Nelly Zuniga, and I'm a psychiatric mental health nurse practitioner provider at Resolute, and we're located in Longview, Texas.
Thank you so much for joining us today. Jasmine Vidal.
Hello, everyone. My name is Jasmine Vidal, and I'm the TxRx Echo Coordinator. Thank you for joining us today.
Thank you. And with that, we will move on to our didactics. Dr. Wakhlu, you can take it away whenever you're ready.
Is everyone able to see the slide and audio is good?
Yes.
Thank you so much. So today I will primarily talk about benzodiazepine use and opioid prescribing in the country. What are the current trends? And going to my first slide, I do not have any disclosures. And our objectives are basically current benzodiazepine prescribing trends in the country and analyze the co-prescribing of benzodiazepines or opioids by provider and specialty, And there's a nice study from the University of Michigan, Ann Arbor, that I'm going to present some data on, and about clinical concerns that you're all familiar with with co-prescribing of benzodiazepines and opioids. To those of you who know me, I'm a big history buff, so I like to talk about history. And our history with benzodiazepines started in 1955 when Roche chemist Leo Sternbach serendipitously identified the first benzodiazepines, chlordiazepoxide. And 5 years later, in 1960, Roche marketed it as Librium. And then 3 years later, diazepam or Valium was introduced in the market, and Librium and Valium became commercially very successful for some years. In 1965, oxazepam was marketed under the brand name of TxRx, and in 1971, lorazepam was synthesized in an attempt to produce a more potent benzodiazepines. In 1977, benzodiazepines were globally the most prescribed medications. And again, at that time, we had really not realized their abuse potential. We used them very liberally. And the first reports about benzodiazepine addiction and misuse and abuse appeared in the literature and news media in the 1980s. And between 1998 to 2005, came the class of Z drugs. The first agent that was marketed was Zolpidem, followed by others. And so in that 7-year period, we had these several Z drugs that came to the market. It again marketed as non-benzodiazepines, but clearly, as when you read the pharmacology of the Z drugs, they work at the same receptor sites that benzodiazepines work at. So, and again, tend to have abuse potential, misuse potential, like benzodiazepines. And these were the initial ads for benzodiazepines: sweet, refreshing Valium, and Xanax makes me a better man. So I've always said that the pharmaceutical marketing of opioids and benzodiazepines and other substances all started off as these were non-addictive, non-habit forming. But again, in a few years, the truth becomes very apparent when they actually hit the market. So there's a long history of pharma marketing that's very misleading, and so these are just some of the few examples of that. So what do we use benzodiazepines for? Again, clearly they have a value in clinical medicine. They're used to treat seizures, especially when people have what we condition called status epilepticus, a series of seizures, and they are very useful. People who have an acute manic episode, they can really be very useful in decreasing the agitation in mania. In general, used for acute psychiatric agitation or behavioral restraints, for example, agitation secondary to drug intoxications, so they can be very useful in that. Management, of course, the greatest use for us in psychiatry and generally in the world of mental health is management of alcohol and drug withdrawals, where they have a lot of value and use in treating, and they're life-saving. They're really because, as you know, drug and alcohol withdrawals can be fatal, life-threatening. So benzodiazepines really have a clear value in helping with the acute withdrawal symptoms. They're also used for periodically moments in sleep, restless leg syndrome, REM sleep behavior disorder. They're used as kind of pre-anesthetic for acute anxiety and apprehension in surgical, dental, other procedures. People sometimes who are really claustrophobic, have difficulty getting into an MRI machine. They're used to pre-medicate so that people can tolerate the procedures. And then they also have a value for musculoskeletal spasms, people with spasticity syndromes, that they can be value for again. So again, they have a value. They really have a value prescribed well for conditions. So my next slide is I have just this one slide on on these novel designer benzodiazepines that are are available to our patients that have flooded the internet drug market. So I've just named a few here: the fluarprazolam, bromazepam, and fluoromazolam, which is a triazo analog of fluobromazepam, etiozolam, clonazepam. Clonazepam is a triazo analog of clonazepam, which is twice as potent as alprazolam, and bromazepam. So, like I said, these are a few designer benzodiazepines on the market. They, like I said earlier, they have an increased presence and availability on the internet drug market, and there's total lack of regulation. Anyone can access them on the internet. The concern about them is increased potency, and some of them have much longer half-lives as compared to the FDA-approved benzodiazepines that are available for use. And some of these designer benzodiazepines, their potency is so intense that they are available in micrograms, not even milligrams. They're so again, and again, as you know, they are not. We cannot test them on routine drug testing. So it's very important to ask patients about if they have been buying benzodiazepines or other prescriptions through the internet, and because that really kind of plays a major role in there. That your management of a patient can really change a lot based on the history that you get from the patient. So again, being mindful of asking this question about novel designer benzodiazepine. So I generally ask the patient, I said, hey, and I know they don't screen on drug screen, so I generally ask them, are you taking any of the substance that you're buying from the internet or on the streets that you have been using? Because I ask that primarily from a safety perspective. Is there's something else we need to do to help you? So, and generally most patients will come out if they have been using designer benzodiazepines. They'll tell me what they have been using. So, and again, that changes my management plan. So, what are our current prescribing trends? So, according to IQVIA, which is a healthcare marketing, they're a healthcare marketing consulting and research company. We have about 34.6 million alprazolam prescriptions and X prescriptions, 21.3 million lorazepam or ativan prescriptions, 23.7 clonazepam or clonazepam prescriptions, and 9.1 million diazepam or Valium prescriptions, and 4.7 million temazepam prescriptions dispensed in the US in 2021. And the trends that we saw were the number of patients being co-prescribed opioids and benzodiazepine increased by 8 to 31% between 2002 and 2014. And if you recall, current opioid prescribing started kind of picked up in the late 1990s and further picked up in the early 2000s, peaking around 2012 when we had the peak of our opioid prescribing, and along the same time we had a rise in the use of benzodiazepines and people generally kind of being co-prescribed them. And along with this, I've not mentioned that in the slide, we also had a rise in the prescribing of a substance, a muscle relaxant called carisoprodol or soma. So we saw these similar trends. And if you look at the pharmacology of carisoprodol or soma, it's very much a sedative hypnotic, like it works very similar to barbiturates. So again, those were again the just adding to the lethality of the treatment cocktails that patients were receiving. And approximately half of these patients received both prescriptions from the same prescriber on the same day. And co-prescribing was more common in patients who received opioids for 90 days or more, and in women and in the elderly. Sorry. So what about currently, since 2016, what have we seen? We have some good news. We have seen that the co-prescribing of opioids and benzodiazepines has declined steadily, but remains elevated for this subset of people who are on chronic opioids, non-Latinx Caucasians, women, and those with Medicare or commercial insurance. And especially in the Medicare population, it's generally the elderly. So the same subset that we had concerns about earlier from 2012 to 2014 is the same subset that we continue to be. The subset seems to be of concern, and this is that people who are on chronic opioids, non-Latinx Caucasians, women, and elderly. So the same subset that we have concerns about now since 2016. Next slide is looking at this is a study that was done primarily in 44 states. This is data that states provided. So 44 states in Washington, D.C., and the 6 states were excluded because the data was missing or there was inconsistent. And these were number of Medicaid outpatient prescriptions for opioids. And the one in orange is prescriptions used to treat opioid use disorder or reverse overdose. So primarily buprenorphine or naloxone, and the one in blue is prescriptions used to treat pain. And as you can see, the trends of the number of opioid prescriptions used to treat pain has gone down in the Medicaid population, and again a rise in the number of patients who received buprenorphine to treat opioid use disorder, and the rise in the use of naloxone. So those are but we are clearly seeing a trend in going in the number of opioid prescriptions kind of scaling back with time. So again, this is our safety concerns about co-prescribing and overdose deaths. So if you look at this is data till 2022, and we have about 10,964 deaths with all benzodiazepines, where benzodiazepines were found in toxicology results. And then the yellow line is benzodiazepines in combination with synthetic opioids other than methadone. And then these were just benzodiazepine alone without any opioid. So again, as you can see, since the late 1990s, we have seen an upswing in the number of deaths, and the concerns about co-prescribing is increased lethality, increased risk of overdose deaths. So this is a study that I talked about that was done by Dr. Most and Dr. David Most and his group at the VA healthcare system in Ann Arbor and the University of Michigan. So what he analyzed data about benzodiazepine prescribing to Medicare beneficiaries, and this was a paper published in 2018. But even though this is a 5-year-old study, this is a 6-year-old study, but this still has relevance to how we practice today. And so the goal of the study was to determine county and provider characteristics that predict high-intensity benzodiazepine prescribing by primary care physicians to Medicare beneficiaries. So that was their goal. And they basically that N was about over 122,000 PCPs who prescribed 37.3 billion medication days. And the primary outcome was the intensity of benzodiazepine prescribing at county and physician level. And benzodiazepine prescribing was taken as days prescribed versus total medication days. That's how we saw it. And they also reviewed the area health resources and the county health ranking. So these were the results of the study, that $300 million worth of benzodiazepines and a total of 1.2 billion total days of benzodiazepine prescribing. Benzodiazepines comprised about 2.3% of all Part D medication days. And PCPs were largely accounted for 61.9% of benzodiazepine prescribing overall, about 728 million benzodiazepine days. So again, which trends continue to be similar. Large majority of prescribing is still being done by primary care physicians or primary care providers. Short-acting benzodiazepines were prescribed most commonly, alprazolam and lorazepam. And states with the highest county level prescribing were all South: Louisiana, Florida, West Virginia, Tennessee, and Alabama. So when we did a kind of a county level analysis, what did we find? In a county level analysis, only in all these high intensity counties that were primarily found in the Appalachian region and South Central states. And these counties were more rural with low socioeconomic status. And they had fewer PCPs per 100,000 population, and fewer even had a psychiatrist. And they fared poorly on every health status indicator except for binge drinking. they had more days of poor mental health and higher suicide rates, and they had a higher proportion of disability eligible Medicare beneficiary. Now the next line was the finding was something that was very concerning, was majority of the benzodiazepine prescribing was in the absence of a mental health diagnosis. And also the prescribing was in absence of a mental health diagnosis and in response to distress in socioeconomically disadvantaged counties, which is called the Case and Deaton hypothesis. So Anna Case and Dr. Deaton are faculty at Princeton and University of Southern California, and they have come up with this hypothesis that that what we have, the trends we have seen in most developed countries is that longevity is kind of on the increase, but what they found was that people who did not have a college degree in the country, their mortality rates were higher and their longevity was on the decline, which was surprising if you considered all the major developed nations, except the US, Canada, Western Europe, Australia, that we said people were living longer, but there was this trend in people who did not have a college degree in the country that the mortality rates were going up, and the current alcohol and drug epidemic was playing a role, and the opioid prescribing and the benzodiazepine prescribing was playing a role, and the use of opioids and benzodiazepines was because of the socioeconomic distress, all the Rust Belt industries kind of no longer existing, jobs moving abroad. So that's what that was their hypothesis. This is the trends we are seeing are not only driven by an inappropriate prescribing, but also driven by social changes that are happening in the country. So it's a beautiful, if you find time, it's really a beautiful synopsis that they've written, and so there's a short video that a YouTube video that I want to show you about, which summarizes what they are kind of talking about. And they call it deaths of despair. Yeah.
As a definition of deaths of despair, which we use as a shorthand, we're talking about drug overdose, alcoholic liver disease and cirrhosis, and suicide. The 20th century was a century of amazing health progress. Mortality rates in the U.S. declined 2% a year on average for 45 to 54-year-olds. And in countries that look like the United States, that kind of progress is continuing. So it was a great surprise to us that in the last years of the 20th century, progress in the U.S. just stopped cold. And in some years, mortality rates actually started to go the wrong way.
The deaths really began to pick up in the late 90s, but the economic and social distress has been just unwinding for a really, really, really long time. And then the opioids threw fuel on that fire and turned it into a full-raging epidemic.
Because this work started with suicide, it was focused primarily on whites, largely because it's a rare event for African Americans to kill themselves. What we see happening to the white working class now has many parallels to what happened in the African American community 50 years ago. When manufacturing withdrew from the inner cities, it left a core of people without jobs. Men became less marriageable, and out of wedlock childbearing increased. And then on top of that, there was a crack cocaine epidemic. Those things have some parallels with the white working class today. When jobs are lost, men are less marriageable, people are cohabiting and having children that the fathers may or may not know in another 10 years. All of the things that used to hold life together and give life meaning, work, family, religion, those things have pretty much disappeared for the white working class.
The big divide we found is between people who have a bachelor's degree or more and people who do not have a bachelor's degree. There are fewer and fewer jobs for people who are less educated. Some of them accept jobs, for instance, in outsourcing firms, which really are jobs that it's very hard to make a good life.
Why has this happened to jobs in the U.S.? And why hasn't it happened to the same extent in Europe, which have also faced globalization, which have also faced the rise of the robot? And we think a large part of this we lay at the doorstep of the healthcare system in the U.S.
people like to say we have the best healthcare system in the world. And they say that over and over again, but I don't know what the data are for that. There's going to be a revolution or something. I mean, you just can't suck this out of the economy.
Healthcare in the US is the most expensive in the world, and it delivers the worst health of any rich country. I think we won't find a real cure for these deaths of despair unless we, first of all, find a way to rein in the costs of the US healthcare system. And second, we need to think more about what we do through K-12 education. But like the healthcare reform, that's going to be a really heavy lift.
This was my last slide, and Jasmine, how do I stop sharing? Oh,
Thank you. Thank you so much, Dr. Wakhlu, for this wonderful presentation. I will now open up the floor for any questions or comments from our learning community here.
Dr. Wakhlu, the graph that you shared showing the trends of the opioid prescribing, with the opioid prescriptions decreasing and the buprenorphine prescriptions increasing over the course of the last few years, that was just for CMS patients, or is that indicative of a more global trend across all prescribing?
no, that was CMS prescriptions, and so that's there was a recent perspective in New England Journal of Medicine on since the waiver was eliminated in January of 2023, has the number of opioid buprenorphine prescriptions in the country have gone up. Unfortunately, we have seen number of prescribers have increased clearly because there's no requirement for, but the number of buprenorphine prescriptions to treat opioid use disorders have remained almost the same. So so I think those trends that you saw was primarily Medicaid beneficiaries, but I don't think that trend has increased dosing has kind of plateaued out really, unfortunately. Yeah.
This is Helene Alfonso from John Peter Smith in Fort Worth, Texas. I was wondering, sir, what is your opinion with prescribing benzodiazepines with Suboxone?
So, as you know, people at the greatest risk of abusing benzodiazepines are the ones who are on long-term opiates. I don't think we have data for people on long-term benzodiazepines, but clearly the risk is higher for people who are on long-term opiates, who are on higher dose of benzodiazepines, who have a history of a substance use disorder, especially of IV drug use, and who are on methadone maintenance. So I think it should be a very detailed and thoughtful discussion with the patient if you're going to go the benzodiazepine route. I prefer not to, but then I'm also mindful of patient needs. And I will say this, I have done it very occasionally where I have felt there's a strong clinical need where the patient's anxiety could derail their recovery. When I have tried other non-benzodiazepine options and nothing seems to have worked, I have from time to time, very occasionally, gone the route of benzodiazepine use, but after much thought and after multiple trials of non-benzodiazepines. So I think one should be very cautious, and because I like to tell my patients before I can do any good, I don't want to do any harm. So that's my philosophy. Again, Helena, to your question, I'm not totally opposed to the idea. I'm not like, man, I'm not going to use it, but I'm very cautious and very conservative when it comes to that.
Thank you, sir.
And I would like to add to Dr. Wakhlu, because back in, I believe it was around 2016, the FDA had placed a black box warning on buprenorphine to not co-prescribe buprenorphine with benzodiazepines. And that led to a lot of prescribers, if a patient was positive for benzodiazepines, they would stop the buprenorphine prescription. So less than a year later, the FDA actually reversed that decision and took away the black box warning and was like, hey, yes, use caution. We put this here to say use caution, not completely cut off a patient, because if you completely cut off a patient, they would return to using whatever opioids they were using before, which is of greater risk because it's a full opioid instead of the partial opioid that buprenorphine is. So it's kind of two sides of the coin when you're looking at, are they already taking it and you're trying to treat the opiate use, or are you thinking about initiating something for the anxiety, and is benzos a consideration?
Thank you, Dr. Walker. I see a question here in the chat from Kim Williamson. What prescription can be used instead of benzodiazepines?
So again, all our SSRIs and SNRIs are basically first-line agents when it comes to treating anxiety disorders. Clearly, as you all know, there's a time lag when they start working. So in the interim, to help with the immediate anxiety issues, I use non-benzodiazepines quite a bit. Buspirone, hydroxyzine, low-dose gabapentin, low-dose antipsychotics like quetiapine. So I have a lot of options that I use and they really work very well. These are options that are very effective for patients before, or sometimes even low-dose tricyclics if a patient does not have any major cardiac issues and all, they tend to work. Sometimes low-dose trazodone, as we said, 12.5 to 25 milligrams 2 or 3 times a day can be a good anxiolytic. So we have multiple options to treat anxiety before we even have to think about benzodiazepines.
I just might add too that some of the anticonvulsants that we use for bipolar kinds of conditions can actually be very effective anti-anxiety. And also some people with chronic sort of depressive disorders really respond better to mood stabilizers than they do to SSRIs, especially if the people have, don't tolerate a couple of different SSRIs. So that's always something that's worthwhile considering as well.
I can add one thing about anxiety. I think one thing we don't think about when treating anxiety is a very unspecific term. And what anxiety means to me may not be what anxiety means to Dr. Walker. And so many times, I think one of the first things when doing an anxiety evaluation for you, think about benzos. When I worked in a rural area, benzos were used all the time, and it's because they kind of treat every part of anxiety. They treat overwhelm, they treat worry, but it doesn't treat anything. It just band-aids over a bullet hole, right? So the idea is to be very cognizant of what is causing their anxiety. Is it food insecurity? Is it having is it psychosocial stressors Dr. Wakhlu is talking about? Is it the fact that there's undiagnosed PTSD that you wouldn't necessarily know about unless you asked? And so I think part of when you're thinking of using a benzodiazepine for anxiety is really getting into why are they wanting a benzo? And most time a patient wants a benzo because it gets rid of, they don't have to think about why they're anxious. They just know it goes away. That doesn't treat anything. So really delving into that idea of what does your anxiety look like and what is causing your anxiety to fuel can sometimes help you figure out what other ways to go. Because when I worked in a rural area, it was very common to have people on Ambien, Ativan or Xanax, and, oxycodone. And it was because, they worked in the oil field and they had to keep going. And this is just what happened over years, or their doctor retired and they had been on it for a long time. And what I found was there was so much, trauma, abuse, food insecurity, and things that weren't being addressed. So I think one of the things is, as we go through these social determinants of health, and really getting at what causes these things, that's huge.
Yeah, those are excellent points. Well, absolutely.
Thank you so much. This has been a great discussion. In the interest of time, we will move on. Thank you again, Dr. Wakhlu, for the wonderful presentation. In the meanwhile, please keep the questions coming in the chat, and we can keep the conversation going there. Angela, if you could please share the announcements from Beeville, Texas. Thank you so much. To claim your CME credits, you must text by midnight tonight. Please text attend 100-95882 to 844-502-1338 by midnight. Next slide. Do you have a difficult case that you or your team have encountered? CSTAT offers you the opportunity to present any challenge your organization is encountering and receive feedback from our hub of experts and broader learning community. There is no need to prepare a formal presentation. We will provide a case form to fill out to assist with your case presentation. Please email us at cstat@utisca.edu. Next slide. I will invite Jessica Harrison to please share some information about this study from Beeville, Texas.
Yes, hello. Thank you so much. Yes, I just wanted to let everyone know about a research study that Beeville is performing right now. So we're seeking participants. These would be patients that have recently started Suboxone treatment. They would participate in a digital therapeutic in conjunction with their medication treatment. The study is 3 months long, and we do provide compensation. It's entirely virtual, so they never have to visit our offices. If you know of anyone that might be interested, please reach out to us or give them our information. You'll see here we have a QR code that leads to our interest form, and we also have our phone number and my email as well. We'll be recruiting for the next year or so, so please feel free to send any interested people our way anytime. Thank you so much.
Thank you so much, Jessica. Next slide. Join CSTAT for a session titled Telehealth for Behavioral Health Services. This will be on Wednesday, July the 10th at 12 noon. And we will drop the registration link in the chat. Next slide. Please join us for our next session. This will be on Tuesday, July 16th with Dr. Walker. And with that, we will move on to our case presentation. Nellie, you can take it away whenever you're ready.
All right, thank you. I'll share my screen. Okay, can everybody see my screen?
Yes, looks good.
Okay, thanks. Well, again, my name is Nellie, and I'm a psychiatric mental health nurse practitioner at Resolute here in Longview, Texas. And I'm fairly new to the program, well, almost a year into the program, so I do have MAT clients as well. And the client that I'm going to present today, he started coming back in October. He was 40 at that time. He's 41 now. He came in, he is Hispanic. So, our sessions are in Spanish. I am bilingual. And that was one of he was having trouble finding somebody that he could talk to, he could relate to, coming from the Hispanic population. Stigma and there's a lot of stigma when it comes to mental health, when it comes to using drugs. So he started using hydrocodone at the age of 19. He started using it for fun. His girlfriend at that time introduced him to it, and he easily got addicted. He tried methamphetamines, cocaine in his early 20s, but then he just mainly stayed with the hydrocodone for years. 2 years ago, he decided to quit cold turkey. He had lost his wife. He lost custody of his daughter. He was not able to work. And that he mentioned saying he reached the lowest point of his life, and he knew he needed to stop or he would continue to lose everything else. And he was already having a hard time losing his daughter. So he decided to quit cold turkey. He was on withdrawals for 2 weeks. He had really good support from his family that would come and check on him, bring him food, bring him water. But even after that, when he quit, he noticed that he didn't have enough energy. He wasn't able to work for longer than 3 to 4 hours. So he started using Kratom. So this was my first client that I've had that has ever used Kratom. So he was using Kratom initially to help with the withdrawals and the cravings, and it would give him energy. And he said it wasn't advertised that it was being addicting. Well, he started losing, he had been on it for 2 years, and he noticed that he would need to use more and more and more throughout the day to not start having withdrawals and to start having energy. And then he started having health problems. His blood pressure was high. He started losing hair. He was didn't really know what was going on, so he figured it had to do with the Kratom. So that's when he finally started looking, and he found us. So we started him on Suboxone, and he's doing really well. Initially, he was having some struggles, but as he's gotten now that he's stable on the Suboxone and off the Kratom and off the hydrocodone, now we've discovered he has some depression, anxiety, trauma. He was sexually abused starting at age 6 and 7. Again, he didn't get any care or any treatment for his mental health because he was living in Mexico. So now that we have him more stable, his Suboxone's really good. It's working well, no cravings, no withdrawals. He's able to work. He's able to see his daughter more. The depression was something that we had also addressed once we got him stable on the Suboxone. Now his depression is better. We're still working on his anxiety, but now we're working on his ADHD. So now that he's more familiar having a provider that he can talk to in Spanish, and he's able to get all his needs out, now we're encountering all these other areas of his mental health. So I guess my biggest question for him, because I know we've talked about he was using meth at one point, and we don't want to start him on a stimulant. And I guess my biggest question for him, with him being on Suboxone, what's the best treatment for somebody that has a little bit of everything from depression, anxiety, substance abuse, ADHD, trauma, something for his ADHD, I guess, because that's his biggest thing now. Now that we have everything else controlled, his biggest thing is ADHD, and he's really wanting to get more attention and focused and more energized. We were working on therapy. We were working on diet and exercise. He's actually going to the gym. He's eating healthier. He's doing a lot on his end in regarding medication as well. But we're kind of stuck at it right now. We've tried Wellbutrin. Right now I have him on Strattera, and we had gone up to 80, but it was too much. He was feeling really tired, so we went down to Strattera 60. He does have high blood pressure still, and that's something that every time he comes in, I'm like, hey, you have to see a PCP. Your blood pressure is staying high. Your blood pressure is staying high. And I explained to him with the Strattera, it can go high as well. So I don't want to go to the stimulant route with him, but I wanted to kind of see if anybody had any suggestions. He's really struggling with attention and focus, and energy is his biggest thing right now.
Thank you so much, Nelly, for bringing this case and sharing it with us. I see some questions here in the chat from James. How well is his anxiety treated?
We're still not where we want it to be honest. We're still working on it. He's on propranolol. Didn't do good on the Vistaril. I'm also thinking about maybe adding some gabapentin to it in the future. It's okay, but it's not where he wants it to be. He still gets anxious when he has to talk to people, so he'll take a propranolol. family owns a bakery. So he works at the bakery part where he has to sometimes deal with customers, and he's had to step away from working the counter due to his anxiety. But we're also still working on his anxiety as well.
So, Nelly, how did you come to the ADHD diagnosis? What all was used to come to that diagnosis? I wanted to ask you that.
So I did the screenings on him, but he also did it with the therapist. And a lot of whenever we have to do for the program, for the ECHO program, there's certain questions we have to ask, and there is ADHD screening on there too. And that's when he started realizing, oh wait, do I meet some of this criteria? So he did his own research as well, but the therapist and myself, we did some screenings on him, and then he did some on his part, asking his parents how he was as a child, and his mom was like, oh yeah, you did have this, and this. So a lot of the symptoms were kind of putting together.
Zachary, I see you have a question.
Yeah, I was curious, kind of going back to our conversation we had earlier and thinking about his anxiety. I guess my question, and Dr. I guess that getting to my question around, like, is this really ADHD? And one of the things that can be helpful is talking about like his childhood history. And, when you do things like the Winder-Utah, which is one of the things that we can use to diagnose ADHD in adults, it's referring back to when you were a child, like before age 12. Any symptoms that he had when he was a child that seemed consistent with ADHD that would kind of help clarify that diagnosis now?
The attention and focus when he was in school, according to his mom and him, he wouldn't sit still in class. He wasn't able to focus. He wasn't paying attention. He had poor grades.
Yeah. And is he using the methamphetamine to help with those ADHD symptoms? Is that kind of what's driving that methamphetamine use?
No, he used it when he was in his early 20s. He's not using it now.
He's not using it now.
No, he's not using anything right now. No, he's good.
So can you tell me a little bit more about the hesitancy around using something like Vyvanse for him, knowing that the misuse potential is a little bit lower, and that if this really is ADHD, that the stimulant's probably going to be the thing that's most helpful?
Right. Well, I just didn't really know, just with the whole substance abuse history that he has, I always want to try the non-stimulant route first. So I didn't know if anybody had any else, similar cases where they've used maybe guanfacine, clonidine. I know his blood pressure is high as well. And I'm not going to he needs to go to his PCP to treat his blood pressure, but I know that guanfacine can help lower your blood pressure as well. So I didn't know what anybody else has used in the past with similar clients before going to a stimulant route.
Yeah, I think the guanfacine in particular, probably just my take, is probably not going to be super helpful for him if his symptoms are primarily in the domain of inattention. Even for adults with hyperactivity, I don't think that the guanfacine is sometimes super helpful, but it's at least more reasonable, I think, in that sort of scenario. But happy to hear what others think too. But that's my thought, is if the Strattera, you mentioned Strattera earlier, right? Atomoxetine. If that's not, if we tried that, or if it's not an option, I would lean toward trying this lisdexamfetamine.
The Strattera is helping with this attention and focus. It's just causing him to feel tired.
Yes. See, my concern is if he's feeling tired on the Strattera, then his ADHD is treated. That's just my clinical experience. Because, if he, the problem with treating ADHD people that have methamphetamine use is that you get too high and it starts acting like meth, because your brain goes from abnormal to normal. My worry with him is I really wonder if he really does have horrible PTSD, and if it's not being treated effectively, and it's so easy and more socially acceptable to talk about having ADHD than it is to work on the depression and the trauma and the other pieces. Because if your mind is reliving the worst moments of your life constantly, you can't concentrate because you're full. Your bandwidth's gone. So I really kind of feel like I think the strategia is reasonable to continue. If he wasn't getting anywhere on the attention and concentration piece with Strattera being at 60 or 80, I go, okay, maybe we think something else, but he's getting somewhere, and that makes me wonder about what am I not treating, or what is he not wanting to treat?
Yeah.
That's my kind of opinion, because I think about it going, there's a lot of trauma that this sounds like he has, and there's a lot of anxiety that he has, and those things can look like ADHD.
Yeah, I had a couple questions for having had a chance to review your case form, Nellie, beforehand. One was that he's showing some clonazepam on the PMP. Is that old or new? And then I would echo the concerns about the PTSD, and even with the symptoms starting in childhood, I can imagine that a child who's actively experiencing sexual trauma is not going to have great focus in school. So again, I would echo that about the PTSD as well. But I was just curious about the clonazepam that was on his PMP, because obviously that would cause a lot of fatigue, or
Yes.
could potentially. So I didn't know where he was getting that from, if that was just old or new or what.
Is it not on my form? Oh, I'm not sure. Yes, so that's something that I started him on not too long ago, just for the anxiety. And he was at one point taking Xanax from Mexico, so I had to have that conversation with him too, not to be taking Xanax from other countries. And I don't really like prescribing Xanax either. So we stayed off of it we tried not to, but then he was getting to a point where he was sitting in the corner just when getting overwhelmed from work. So we started that, and I did have the conversation with him not to overtake it and only take it as needed. So he's been doing pretty good on that too. Regarding the trauma, I know he's working on it with therapy. We do talk about it a little bit during our sessions, but he feels like there's still more to go. I don't know what kind of therapy they're going to want to work on him, whether it's EMDR or things like that. But yeah, I think we need to focus more on trauma as well.
When it does come to focus, I do find a lot of my patients who are on MAT, they do have some cognitive kind of dulling. Definitely, it does sound like this young man has a long-standing history. In my clinic, I probably would not use a stimulant. I sometimes will do Provigil, which I know is still not the best, but still could be an option for him. Sometimes lamotrigine can be beneficial for the PTSD. If you've ever looked at Amen Clinic's Ring of Fire ADHD, I sometimes show that picture to patients, or I ask them, how did your mother describe you? And if they're like, oh, I was a very rambunctious kind of boy, and usually for the Ring of Fire type ADHD person, a lot of times mood stabilizers can be more beneficial. Unfortunately, I think in a patient like this one, he is not going to be satisfied unless he is maybe taking something like a Vyvanse or an Adderall or a Ritalin, because he doesn't feel it working or doesn't feel like he's able to do things. I don't know if you could meet with the family and maybe say, maybe he might need to just work part-time. He might not be able to work full-time at the bakery, or, I will do tons of letters for accommodations, for extra breaks. That's just some of my experience with that.
Thank you.
I also had a question about his sleep. How is he sleeping? And is that kind of contributing? Is he having a lot of night terrors, or is he getting good sleep at night? Because that could contribute again to just feeling off during the day.
He reports sleeping well now. So he started waking up early in the morning to go to the gym. So that's turned into his schedule now. So he hasn't reported any trouble falling or staying asleep, because he does wake up early. And I know we've talked about that as well, the energy. But he just is just, and he has low testosterone too. So he's been trying to get those injections for low testosterone.
Can I make an observation? I don't want this may sound very bad, and I apologize. This sounds like someone who's still very much in his addiction in a lot of ways. This is someone who's still buying your benzos off from Mexico, who you had to talk with, who's on MAT, and it makes total sense. But I think part of it is recognizing a pill is not going to fix everything. It's just not. And if I had a pill that fixed everything, oh my God, I've retired and been in Fiji. I wouldn't be here. But I think for him, it's going to be a lot of learning what normal is. No one sits in a chair voluntarily. We all had to learn. And if you're being sexually traumatized, as Alicia said, like, you're not paying attention in school. You're not learning even basic things like how to concentrate. You're just not. And I think so there may be some reality kind of thing, you know? It's a piece of I just think that we're gonna have to really work with him hard on what is it to experience emotions and learn things that people learned decades ago. That's hard. It's hard to learn. And I think that that's someone who's still in their mind is, I worry that if you went to the Vyvanse route, it's gonna further that thought process of I need a pill to fix this. Because that's what I'm hearing is I'm hearing more of the story, and I apologize I didn't get a chance to look at everything, but the clonazepam, then the Xanax from Mexico, I think Dr. Alfonso is right. It's going to be very hard, and he may not be okay unless it is a stimulant. But I think that's just my opinion. Yeah.
I'd just like to add one thing. I would not discourage you from trying the guanfacine because I've seen it actually help people that for whatever reason, didn't do that great on stimulants. So, they're more likely to work, but I have several patients on guanfacine and they're doing quite well on it. So,
thank you.
Dr. King, I think the bigger question here is the diagnostic clarification. Are we really dealing with someone with ADHD? I think James had made some good points. This probably this is more trauma spectrum disorder, and what Dr. Kowalczyk also said, rather than someone who has ADHD. So I think that's the bigger issue that we need to figure out. Is this truly someone with ADHD? And then I
don't disagree, Dr. Wakhlu, but I think it's worthwhile keeping a variety of different things in your mind about how you might approach a problem, especially because I was hearing he's likely going to want a stimulant or something. So that was the only thing I was.
But then again, you're throwing another pill in, and the message the patient is getting is, I'm going to give you a pill that fixes your problem. And I don't think that this patient should get that message. And rather than that's all I think. I think this is a very slippery slope living. He's going down alprazolam, clonazepam. He's trying to get testosterone replacement therapy. So those are all big red flags. That's what I feel about him.
So I did want to reflect, though, that, you said he's been with you now in treatment for about 6 months or so, Nellie, and you've managed to do a lot of work with him and keep him engaged. And he's shown a lot of strengths in terms of now being able to work in his family's business, even though it is stress provoking to him. He's showing up, he's working out. He has a lot of strengths that you seem to be reflecting to him and keeping him engaged. And that is no small feat. So I did want to make sure that you heard that. And that, I think this is a great case that you brought forward because it is really complex. And I think there's a lot of ways you can go from here. And I don't know that anyone is jumping out as the right or the wrong way, but just keeping him engaged and, okay, let's try this. Let's move forward on this. It seems to be working well to get him through a lot up to now.
Thank you.
Thank you so much. This has been an excellent discussion. In the interest of time, I will request Dr. Walker to please summarize the case and some of the recommendations.
Okay, we're at the top of the hour, so I'm going to talk very fast because this has been a very robust discussion. But Nellie brought an excellent case of a 41-year-old male, Spanish-speaking, who had previously been in Mexico, not receiving the best care, some history of trauma, depression, substance use, anxiety, and potentially ADHD. Very complicated case, was able to get him on medications for opiate use disorder with buprenorphine for his hydrocodone and kratom use. There was a lot of discussion surrounding his specific diagnoses and maybe a glance into a deeper dive of what his true diagnoses are. Does he have PTSD, complex PTSD? Is that trauma contributing to his potential ADHD diagnosis, or is it masking a PTSD diagnosis? And getting further into that diagnostic criteria, which will help lead to the next steps of treatment. Also confronting the fact that this client has gone really far in the last 6 months and has had a lot of improvement. And so congratulating him and his treatment team on how much he has improved in the last 6 months. There was also discussions about not using a pill as a one fix, fast fix, and looking at alternative therapies, such as in the chat, there was talking about art therapy, sand therapy, things of that nature, looking at his psychosocial, like maybe decreasing his work requirements, helping him through more of those modalities instead of the medication route. But if you did decide to go to the medication route, is Strattera really working? Because could it be working? And that is why he is feeling low energy, because his focus is better and he's reporting his other symptoms have improved, or there was a thought about switching him to the guanfacine because there has been good reports on folks who the Strattera wasn't working well on, the guanfacine could, and that could also help with some of his other conditions. Another suggestion was lamotrigine to help if there is some underlying PTSD and going that route. There was also discussion about maybe he is just wanting a stimulant. So Vyvanse, Adderall, Ritalin. There was a suggestion that the Vyvanse is helpful when it comes to people complaining about these certain specific issues with the focus when it comes to adults. And then also keep in mind that there was a mention that medications for opiate use disorder could have some cognitive dulling. And is that complicating the case? And so that is a lot of information, Nellie, for you to process, take back, lots of opinions and lots of suggestions. Good, robust case and discussion today.
Thank you so much. And thank you again, Nellie, for bringing this wonderful case. And we hope you'll come back to tell us how the patient progressed in future. And thank you all for joining today's ECHO. As a reminder, to earn CE credits, please text the activity code 1009-5882 to 844-502-1338 by midnight tonight. We will be sending this information in the post-session email as well. We also request you to complete the post-session feedback survey using the link in the chat. The survey link will be open for 1 week. If you would like to present a case, please email cstat@ithaca.edu. We look forward to seeing you at our next session on Tuesday, July 16th. Thank you and have a wonderful rest of your day. Bye-bye.